All right, welcome back, welcome back, welcome back to another presentation. And today is one of my best presentations, my best topic, patient assessment. Patient assessment is the number one thing, the foundation of being an EMT. It doesn't matter what call you get, the patient assessment is the foundation. You need to really understand this and also understanding the skill. But as we're doing this, we're learning just the basic fundamentals of it in a presentation. And when you guys go to your skills groups, this is the time we have to practice and practice and practice and practice. All right. Again, well, my name is Zach, and I'm here to be your instructor. All right. I know you guys are in school, and I'm here to provide some knowledge, try to make it as simple as possible for you to get you through your EMT course for the first time, third time, ninth time, 20th time. If you've been an EMT for years, and one of the biggest things is anxiety in the classroom. So I hope that I'm able to help you. So let's get with it. I'm going to share my screen and let's get to the presentation. All right. I hope everyone is doing well. I hope everyone is doing well. So I got that. Let me move this out of the way. All right. I'm going to show the panel. We'll move that up there and take this out of the way. All right. So let me put this up. All right, patient assessment, patient assessment. This is where the foundation is right here. So there are a couple of things you need to understand as EMTs, and especially if you're new, it doesn't matter what state you're from, what county you're from, what region you're from, what country you're from, because there are EMTs all over this world saving lives. But when it comes to that, you have to be a master of this topic in the sense of your skills, interview, assessment, what you're checking for. All right, this is a general vanilla type of assessment in the sense of it's going both to medical and trauma, and it's a kind of a combined thing. All right, so remember this: every master was a disaster. Every master was a disaster. I'm speaking for myself. When I first became an EMT, I was a disaster. All right, there were some things I didn't learn. I mean, I learned, but I just didn't apply because it's all about inexperience, and he becomes experienced, and then it becomes second nature, and you basically will master a lot of the skills and the ways it's done. So here for patient assessment, there are only five major main parts. Let's look at the five parts here. Seeing size up, primary assessment, history taking, secondary assessment, and last, reassessment. All right, so now we're going to go to the first section, which is seeing size up. This is when we have to size up things. We have to size up the scene itself. And when that occurs, when it first happens, it happens when we get dispatch or we get that call. We see it on the computer on our ambulance. All right, we get the call type. It gives you a little description of what's happening. This is where our scene size up take place. If this particular call happens, we're thinking of this. If this happens or this type of call, we're thinking about that. So we always are aware. We're always gathering information and then creating a size up, observing the scene at all times. All right, things can change. So as you enter the scene of any scene, any location, we're always going to use something called situation awareness. All right, situational awareness, which means that we're going to be aware of our surroundings. And usually it's like a 10-second assessment, basically doing a scan, looking at around, making sure everything looks good. If it's not, we'll talk that more in details in a few minutes. All right, so the first thing that we're going to look at is something called standard precautions. All right, standard precaution, AKA, or in other words, BSI. For those who's been on the job for a while, you remember body substance isolation, BSI. So that's what we're going to look at. This was important because we're going to find out why. And I know I spoke about this earlier in wellness. We talked about the pathogens and talked about the different airborne, bloodborne, and this is where we protect ourselves. All right. So we got to wear our personal protective equipment, PPE. Now, notice here I have a mask with a face shield. Here I have a gown with my gloves, and my gloves is literally over the gown just to protect. And I have goggles and a face mask. All right. So this is something you want to always be aware of. And here we have some gloves going on. All right. Some gloves, some eyeglasses, or eyeglasses not 100% because again, you have the side lateral areas that can be exposed, but having a face shield is important and a mask, as you notice here, or goggles, excuse me. Then you have the mask for those airborne pathogens. And that's what you need to have. That's a very important thing. So wear your personal protective equipment. All right. The next thing. So that's the first. The second thing is your scene safety, making sure the scene is safe, safe, safe. All right. So this is something that we always check from the very beginning all the way till we get to the hospital. You know what I mean? So, because things can change. It has happened to me in the past where, everything looks good and then suddenly things turn literally really, 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 really fast. So we have to enter the scene. We have to make sure my scene, my safety is very secure. I'm good. Then my partner, then my partner, my patient, and then everyone else. So again, my safety is number one, my partner safety, my patients, and then bystanders. There are pretty much steps along the way. Whose priority is me? All right. So your safety is number one. Make sure when you enter the scene that the scene is safe. All right. And if you happen not to feel that the scene is not safe or something's happening, you want to make sure you want to call for additional resources, especially if it's not safe. So I will hold back, find a safe location, notify the dispatcher to get police, and they'll ask me what's the condition. I'll give them the condition of whatever the scenario is in this particular scene. Excuse me. The way you enter is the same way you exit. Okay, so when you enter an apartment, make sure you look at the apartment. There's nothing that's going to, just in case something does occur here that you get stuck in the apartment, but we're going to enter it and we have a way to escape in case you need to. So that's something you need to keep in mind. All right, dogs. Look at this nice dog here. You know what? I'm the owner of this dog, and guess what? He doesn't bite. He's my dog. He's a great dog. So one rule I have is when I enter in a house and I hear dogs, I see a dog, can you kindly place the dog, secure the dog in the room, the bathroom, whatever it is, because that's again, they say the dog doesn't bite, but again, dogs do bite. They're dogs. So just keep in mind that secure all animals away that you feel is going to be a danger. And one thing for me, it will be those dogs. All right, next. So we did the BSI, standard precaution. Now we went into the scene safety. Now we went into the next level. The next level is mechanism of injuries. I'm going to stop there. So mechanism of injuries. So people get confused, MOI versus NOI. Most people will say that, but say the words is mechanism of injuries. The third word is the big clues. So mechanism of injury, trauma, nature of illness, medical emergencies. All right. So the mechanism of injuries is interesting. Here we have a motor vehicle crash. Obviously, we see the impact. So when we get to the scene, we're looking at all these different clues. We're looking at the wheel. We're looking at the airbag. We're looking at how it's dented. So we're thinking about a lot of potential force to make this occur. And we're looking at the type of force. We're looking at the prediction of the severity of the patient's injury. So we can make a prediction. There could be some hip injuries, leg injuries, head injuries, definitely neck injury, all right, due to the impact. All right, another good key thing is airbags. Airbags come out very, very fast. And again, we have the windshield. You see it crack or have a whole bunch of patterns there due to the impact, whether it's from the airbag or from someone's head hitting the windshield. If they have hair and there's hair in the windshield, that's a clue that they hit the head. All right. So those are just some of the things that you're going to be a detective. Okay. Nature of illness, medical. All right. So you have a guy here in a tripod position. So this is known as the tripod position. This is a sign right here that I know this patient having respiratory distress. All right. So you can ask the patient what's going on. You can find out what's really happening. You can ask the family members. Maybe the patient is actually not responding. Patient is confused. So the family members call and call for us. So they can give you a lot of information. All right. Bystanders, you're in the street, someone gets hurt, someone gets sick. They call 911. They're just a bystander. So they can give whatever information they can based on what they saw on the scene to give us more clues because you are a detective, especially in the medical calls, the nature of illness. So after that, the next step is going to be determine the number of patients. You're going to one patient and suddenly you come out with five, right? It has happened to me. So the number of patients is important because when it becomes overwhelming or multiple patients, then this would be declared as a mass casualty incident or MCI. And in order to do that, you have to do something called triage the patient. I'll talk about that in operations. I have triage tags. I'll show you the colors, matching the condition to the colors. But one person need to, especially if it's a mass casualty, if it's a fire or something, explosion or something where there's many patients there, you're going to have to go straight to the incident commander, the IC, which would be a fire chief in some municipal areas, maybe a town, but you will have a EMS supervisor part as of this operation. So it all depends on your state and region and what part of the world you're from. But when you have multiple patients, you need to call for additional resources, which is going to be the next thing. So number of patients and triage is an interesting word that comes from the French word to triage mean to sort out the different types of patients, the conditions that qualifies them for a specific assessment that's going to take 30 seconds or so to do. And you have to give them a specific color based on their condition. We'll talk more about that in operations, and I'll make you a master of triage. All right, the next component is additional specialized resources. Specialized resources here. So you get to the scene, you're scene safe, you get this, you get that. Now you notice something that your patient might need, some extra care, or the scene is a little hazard, or it might be a safety issue here. So let's go through it here. So let's say I'm the crew and I need backup. I can call for another BLS, basic life support, aka EMTs. Or I can call for additional resources, which is a next level of training, which I spoke about on the first presentation, Introduction to EMS. And we have the advanced life support, ALS, which is paramedics or medics, they call them. All right. If there is a fire or there's something that we need to gain access to the patient, we will call the fire department. The fire department will be those for hands. They can also assess. They can also help to extricate a patient out of the vehicle as well as an apartment. Then last, we have actually second to last, we have the hazard material. You're responding to the call. On the highway, you see a truck on its side, and there's fluid coming out, and a big old mushroom cloud with a color on it. I'm just exaggerating, but this is just an example. So you call for hazmat or hazard material, and these individuals were trained to get into those scenes, all right, assess the scenes, and they have suits that has different levels of protection. And last but not least, we have the PD, police department. All right, so in adding that, with the MCI that we spoke about before, we have many patients. Then now we have resources. So with the resources and in the resources, then we know exactly who we want to call for safety police. If it's gaining access to something or if it's a potential fire. All right, so we're gonna know who to call, and guess who we have to go to? Go to the dispatcher, which is on your radio. Let them know the condition, and these are this is what you're requesting. All right, so we finished with the scene size up. Very easy. You can go back in the video and stop. But here, this is the primary, exactly what the word says, primary assessment. So here's the goal. The goal is to identify, finding it out, looking at it, initiate treatment. Why? How? Of immediate and potential life threat. So in the primary, very important term, in the primary, you have to identify it. But you're identifying potential life threats, and you're going to treat it immediately. All right, that's the goal of the primary assessment. So as we go into the primary assessment, we have a name called Lisa. Everywhere has mnemonics. You're going to learn a lot of mnemonics. And for those who've done the job for a long time, yes, we're back. Now, if you're from a different state or a different county, there are other mnemonics that's going to assess this. So this is just one way of looking at it. So in Lisa, we have life threats, general impression, stabilize the C-spine, and AF-proof. All right, so what is a life threat? Very simple. A life threat is something that we have to fix immediately. All right, airway obstruction, they're choking. We stop everything, abdominal thrust until the object comes out. Respiratory arrest, they're not breathing, so we got to breathe for them. The patient is on fire. We got to stop the burning process. There is a severe bleed. Stop the bleeding. So again, these are things that is going to stop everything, assess it, and then fix it. Cardiac arrest, then that's where we will go and start our compressions and ventilations, compressions, then get the AED, automated external defibrillator. All right, L, life threats. So we have to find them. I stands for impression, what you see with your eyes. Not I, right? Impression. I just put an S. Eyes, what you're looking at, age. You're looking at the gender. You're looking at the position, whether they're in the tripod position, they're laying on their back, which is called supine, and find out if it's the nature of illness or the mechanism of injuries. LIS. S stands for stabilizing the C-spine. This is the cervical spine here, right? We spoke about this earlier in what is that thing called? Human body, right? So we have to stabilize it because there is a potential injury to the cervical spine. There is, whether the patient is standing up, sitting down, or laying down, or even laying down prone. There's techniques to log roll them from off the floor. Well, log them, roll them, and then place them in a transport device. So stabilizing the C-spine, whether it's going to be medical or trauma, it applies to both depending on the situation that you get. All right, AFPUF, AVPU is a mental assessment. So we see people, we talk to people, we look at them and they look quite fine, but when you ask them questions, they might not be here. They might be somewhere else. So let's look at some of the things that we're going to be looking here. We got A, alert. That's what it stands for, alert. So with alert here, you're going to ask them questions. So the questions you ask them is the four W's. 4 W's. What's your name? Where are you? What time of day it is? And what happened? 4. The W's. With the W's, you're trying to get an open-end question. That's all you're doing, because that's going to get some information into the patient, into you. You're going to get the information from the patient. Then you have V, which stands for verbal, right? Verbal. Patient. So let's go back to the alert. All right, so their question. Remember the question I said, what's your name, where are you, what time of day it is, and what happened? If they answer all 4, they are alert. Next is V for verbal. So now the patient only answers very few of the questions. They're considered to be verbal. Patient's looking off to the side, and suddenly you say, hello, hey, and they turn their head and got their attention, then they'll be considered verbal. And next is P for pain. Patients laying on the floor. You shout, hello, hello, are you okay? No response. You tap on both sides because the patient could have a stroke. Pat, 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 right? With a pet. Then no response. And then we're going to check for patient's responsiveness. So we're going to pinch the trapezius muscle. And if they moan, groan, or cry or response, they are responsive to painful stimuli. That's what the P stands for. And if you did everything, you call them out, you tap, 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 you pinch, and nothing, no response, the patient would become a U, which is unresponsive, which is not a good thing. All right, mnemonics, alert, verbal stimuli, responsive to pain, and unresponsive. That's something you need to know. All right, moving forward, we have something called the complaint. Oh, wait, no, it's the chief complaint. There's a complaint going on, but it's the chief complaint, which is the most serious thing the patient is complaining of about the reason why they call us. All right. So why did you call EMS? Oh, my chest is hurting. I have a headache. They're giving that complaint. That's the reason why. That complaint gave them a reason to call the ambulance to go to the hospital. So back to the mental status test. Basically, it's assessing not just any questions, but these questions are specific. So what is your name? Where are you? What time of day it is? And what happened? So this is evaluating the long-term memory, intermediate term memory, and short-term memory. These are the reasons. All right, responsive to painful stimuli. Hello, 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 no response. Pitch the trapezius muscles on both sides. And we have something that used to call the sternum rub. And guess what? We're not doing that. All right, now we're moving on to the Lisa alert. Now we're going to the ABC. So the ABCs here, we have A for airway. We have to make sure that the airway is patent. All right, not patent, but patent. And which means open and adequate. That's all we're checking for. Very important. That's why it's ABC. Responsive patient. We're going to have two scenarios. We're going to have a responsive patient, and then we're going to have an unresponsive patient. All right, you guys are with me? Good. So responsive patient, if they're talking or crying, guess what? The airway is completely open. That's a great sign. All right, now I'm going to check for the patient, the way their patient is talking. All right, how they're talking. Labored breathing. Next is going to be the unresponsive patient. We're going to assess the airway. There's only two ways to open the airway, but let's go back. I'm laying on the ground. All of I'm unresponsive. All of my muscles and everything is relaxed. My tongue now falls where gravity takes it and blocks the airway. So now the question is, what maneuvers is going to help me to open this airway? Very simple. One is called head tilt, chin lift. Head tilt, chin lift technique, which you're going to place one hand on the forehead, pretty much doing like that, and then pull or kind of hold the chin, head tilt, chin lift. And that's going to open the airway. It's going to remove the tongue in the sense of it's going to move it out of the airway in the sense of blocking. It's going to go up and forward. But now in the other scenario, we have a person who got, let's say, hit by a car or fell off a ladder or fell off a building. And we know that there's potential trauma to the neck and all these other areas, but mainly the neck. We're going to use a technique called the jaw thrust. All right, the jaw thrust. And guess what? The common cause of airway obstruction is the tongue. So you know. All right, in the breathing step, we're assessing the presence, if it's there, or inadequate, excuse me. So first you ask yourself, is this patient breathing? That's important. Is the patient breathing adequately? That's another question. So these are questions that we're also asking. And I believe we cover this in the airway lecture. So we're checking for breathing. Are they breathing normal, not normal? Are they using accessory muscle use? Are they having nasal flaring? Their nostrils flare up. Are they using the cash my breath, which is the 2 to 3 word dyspnea and labor breathing. All right, let's look at the process of it in breathing and respiratory. First, you have the respiratory distress, increase. Things go fast. Breathing goes fast. Heart rate goes fast. Everything goes fast, right? Difficulty breathing is there. Adequate tidal volume is going well. That's the distress. Now we're going to the worst case is respiratory failure. So this is when there's inadequate oxygenation, ventilation is inadequate to meet the demands of the body. The body needs oxygen. So if it's not happening, they start going down this spiral. So as they're distress, everything goes up, heart rate, breathing. Now as they go into respiratory failure, things starts to slow down, pulse starts to slow down. All right, all these things starts to slow down. And respiratory arrest, which means it stopped. They're not breathing. This is where you're going to start to play and give the patient the appropriate device, which will be a BVM, bag valve mask. All right, now we're moving to, we did that. And now we're going to the circulation. The circulation here is a pulse. All right, so we have a whole bunch of pipes, if you want to look at it, in our bodies. And these pipes are running through with blood, not water, but blood. So now, as we see these pulse, it's going to be a pressure wave that occurs every time my left ventricle contracts, is basically sending a ripple effect. And this is where that peak of it is where we feel that pulse, or palpating the pulse. So we have here the radial pulse and the carotid pulse. Then we're going to move on to the next step, which is bleeding. We're going to assess to see if the patient is bleeding from outside or if the patient's bleeding from inside. So there's very quick 3 questions for internal. Ask the patient, have you noticed any blood in your urine, blood in your vomit, or defecating any blood? And if they say no, we're good. Now we're going to go to the skin, right? The skin. So with the skin here, we're looking at the skin condition, right? We're going to look at this thing called the CTC. It used to be C, but it's called CTM, the color, the temperature, and the moisture. That's what we're really checking for the skin. It's the largest organ in the body. Then as we go to pediatrics, we have something called the capillary refill. All right, we're assessing that. We'll talk more in real details on that later. Now let's go to the CTC. C stands for color, or the CTM. And this is the color of the patient. So now we're not just saying, oh, the patient is gray, the patient is blue, the patient, damn, he looks yellow, or he's red. No, we're going to use the medical term. So if the patient is white, they're pale. If they're gray, they're ashen. If they're blue, they're cyanotic. If they're red, they're flush. And then if they're yellow, they are jaundice. So this is pretty much the colors that we can be presented with patients. CTM. T is the temperature. So the normal temperature should be warm, 98.6 degrees. Then we have the abnormal, which is where it is too hot, or too cold, or just cool. Then we have the moisture. The moisture is easy. Basically, if the skin is just dry, that's normal. But now if the skin is wet or moist or diaphoretic, it's just pouring out sweat. All right, moving forward, we have to determine the priority of the patient's care, right, and transport. So these are the high priorities, which is an unresponsive patient. Just a really bad general impression of the patient. They don't look at all. Something along the lines with difficulty breathing, uncontrolled bleeding. Then we have the altered mental status, confusion. There's many reasons why this can happen. Chest pains, and definitely a complicated childbirth. So these are all our high priority patients. Another important thing, got my bell, right? Remember that bell? There we go. So here, the golden hour. The golden hour, for those who's been in the job for a long time, this is no, it used to be called the golden period. But now it's the golden hour. And basically, this is what a lot of people get confused. So this is it. It starts when the time of the injury, and that time goes on and on and on within that 10 minutes, within that golden hour. So from the time of the injury to definitive care. Definitive care is not the waiting room. It's not being triaged. It's the OR, right? This is when they go down and dirty, to the sense of the term, to treat this patient in the most sterile place that you can find. So definitive care. So from the time of the injury until the time they are doing the care that's needed, definitive care. So with that said, we're going to assess, we're going to stabilize the patient, and then we're going to package this patient. So this is going to be, if it's a critical patient, we're going to be leaving. All right, we're not wasting time, just like we might have like a very stable patient. So transport to the ER within the 10 minutes, 10 minutes after the arrival at the scene. So once you get to the scene, there's another clock that sets, which is 10 minutes. It's called the Platinum 10. So that tells you need to get off the scene as quickly as possible. Now, history taking is a different section now. All right, we went to the scene size up. We did the primary. Now this is the third, which is called the history taking. So here it is. You ready for this? OPQRS and sample. All right. So getting the flashback, you're getting the was that blast from the past. But if you are a new EMT and this is a language you have to speak, and these are some questions that you need to know. So here it is. Onset. What were they doing when the symptoms began? Very good question, right? This is what you're going to ask your patients. Propagate. Is anything that makes it better or worse? Quality. How would you describe it in your own words? Regions, radiation. Where do you feel this pain? Does it travel anywhere? And from a scale of 0 to 10, 0 being no pain, and 1 being very little pain, and 10 being the worst pain they ever felt in their life, how bad is the pain? Period. And time. When did the symptoms start? All right, now the next set of questions. So the OPQRST, you can take your time, rewind, and just practice this question over and over again. Sample history is signs and symptoms. Is there anything else bothering you besides the chief complaint, as we mentioned earlier? Then we have medications. Then from medications, what medications are you taking? What is the past pertinent medical history? Well, what is the past medical history? He says to the patients. The samples there, but there's questions. As you see, it's a very dark, dark lettering. Okay. So again, anything else bothering you? Any allergy to food or medication? What medications are you taking? And what is your past medical history? And what was the last thing that you ate or drank and when? That's stuff that you have to know, because what they ate could have been a reaction. What they ate could have, in other words, they could have been the one that they need surgery. So that information is important to give to the physicians, right? The surgeons. So at the end is events leading up to the injury or illness. So what were you doing prior or before the symptoms began? That's a very good question to ask. So get very familiarized with this, and you will be amazing and outstanding. Now we're going to go into the secondary assessment. This is more of a systematic physical exam. All right, we've done everything else. Now we're flowing through. So there is a systematic head to toe exam assessment, secondary assessment. So we're going to focus on the system of the body, figure out what's going on, narrow everything down. And then whatever it is, we're going to focus on that. So it's going to be on the scene, back in the ambulance, and then we have en route to the hospital. So these are things that we can do at any given time, either in the scene, you're in the ambulance, or you're en route to the ambulance. So there's terminologies here. This is going to be the 3 terminologies we're going to learn. Inspect is what you see. Palpate is when you assess, or palpate means you touch, right? Because you're going to have to touch the patient, especially when you're assessing certain things. Auscultating, there it is, the stethoscope is going to be listening in to the lungs or even the heart. Looking at the patient, inspect, touch the patient in the sense of assessing them, and listen to the patient. Oh, here it is, the next one. You guys been waiting for this. I know that for a fact. Probably not, but now you are. If this is new to you, it's new. If you've been on the job for a while, you know what's coming. So DCAP BTLS, you got to assess the patient when it comes to an unresponsive medical or a significant trauma patient. All right, so deformities, contusions, aka bruise, abrasions, a scrape. We have a puncture and penetrations. Then we have burns. This is called DCAP. B, burns. T, tenderness. L, laceration. And S, swelling. So these are the things that you're going to be assessing. Okay, we'll talk more about that, these terms in real big details when we get into soft tissue injuries and things like that. All right, so now we're going to focus on the assessment, a non-significant mechanism of injuries versus a responsive patient. So they're going to get the same type of assessment. This is a very easy, non-significant mechanism of injuries or injury. Then we're going to get the responsive medical patient. So ultimately, the goal is to focus on your attention on that part that's being complained of, that system. Let's go through some of the systems. Respiratory system, obviously, we're going to check to see if there's any airway obstruction. Then we're going to check for any increased work of breathing. Then we're going to assess the chest, depending on what the situation is. And then we have to check the breath sounds or lung sounds. We're using the stethoscope. And there it is. So here, I put this on top because this is called stridor. There is something I've learned from one of my students. This individual said, stridor is always higher, which means it's an upper airway. You hear something up here called stridor, high-pitched sound on the upper airway, and the lower airway is a little different here. So stridor is always higher. That's always an upper airway problem. Snoring, the tongue is in the way. Wheezing, all right, this is when the diameter of the bronchiole starts to constrict, causing that puckering, like you do pucker your lips when you want to whistle. And we get the whistling sound, also known as wheezing. The next one's called crackles. Crackles is also known as rales, and rales, wet lung. So there's three names for the same thing. So crackles, you'll find fluid in the lower airway. And from here, these are all lower airway. And let me go back to the snoring part. The snoring part, again, there's two maneuvers that we can eliminate that, which is, come on, tell me. Head tilt, chin lift, and jaw thrust. Excellent. So crackles, which is the wet lung fluids now, and also known as rales. And last but not least, we have the rhonchi. Rhonchi, we can hear that in the bronchi. We're just changing up the letters. Cardiovascular system. So let's say we have a cardiac patient. We want to make sure that the patient has a pulse. That's important, right? And if the pulse is regular. If it's not regular, the thing I've learned is irregular pulse to the heart, irregular heart, because that's where it's generated from. So it gives you a lot of clues. So let's look at this. So trauma to the chest. All right, you can get something called a cardiac contusion or cardiac bruise. We can get many different things along the chest wall. And we're going to check the skin to see if they're not pale, cool, and moist, because this is another sign of perhaps maybe internal bleeding going on. We also going to check the pulses. Now, if the patient is responsive, that's the radial pulse. If the patient's unresponsive, that is the carotid pulse. All right, we're going to auscultate the breath sound, lung sounds, and that's what we're going to do our assessment. Neurological, here's a different system. It's all about the brain. It's all about what's happening here. So that means if there's head injuries, patient feels very dizzy, or they pass out or syncopize. That's something a little more deeper, and that can be more of a mental status neurological system. Then we're going to check the AFPOOF, which you said earlier. This is just a shortcut assessment of learning long-term memory, short-term memory, intermediate memory, looking at the AFPOOF. And there is a supersized assessment called the Glasgow Coma Score Scale, right? So there's a number sets, and I'll show you more of that in during head injuries. Part of the neurological is the eyes. The eyes is the window to the brain. There's other ways to say it, but here we have, let's just do a quick little recap. This is the sclera. This is the iris, the color. And then here, this black thing is the pupil. So we're going to have to press on the leverage of the pen, and the light shines just like this. So what we're looking for, we're going to actually shine, we'll have them look at an object, a stationary object on your face, your forehead, your eyes, whatever it is. Have them focus on that. If they wear glasses, we're going to remove those glasses, and then we're going to have them have their eyes open. Then we're going to take the pen light, squeeze it or click it, and you're going to start to scan from the lateral to the medial on one eye, lateral to medial, and that eye pupil should constrict with that bright light. All right, as we said before, is a window to the brain. Pupils is a black central part of the eye, and it reacts to constricting. Normal, round, equal, okay? And with no light, it should be really relaxed. So let me just give you a recap. So now if you place a light in your eye, this is what happens, constricts. When you are in the dark, it dilates, okay, that pupil. All right, unequal pupils. So there's some people who might have this thing called anisocoria, which is unequal pupils. One is dilated and one is constricted. So find out, ask them. Here's some other functions. Depressed functions, brain functions, head injuries can cause the pupils. Trauma can also cause the pupils to either, respond a certain way. Strokes and drug overdose. Those are things that we really need to check the eyes. And when we assess the eyes, it's PEARRL. Pupils are equal and reactive to light. That's one way. Pupils are equal and round and reactive to light. So that's another. All right. Depending on what school that you're doing, you can kind of match up their thing. Then we have the neurological is going to assess the weakness of the extremities, the arms. We're going to have the patient squeeze, or if they can't move their arm, that could be possible stroke. Pain and sensation, again, that's another thing. And comparing the distal pulse to a proximal pulse in sensory response, very important. All right, so this is just the basic stuff here. We're doing assessment. We're doing a head, neck, and cervical spine. We have the scalp and the skull. We have the patient's pupils. We're going to assess it and check the pen light. We check in the white part of the eye, which is the sclera. We check in the cheekbone. Here, we're going to check major areas of the skull. We're not putting too much pressure, but we're checking for anything that will be abnormal. And checking the ears for fluid, blood, right? And then we're checking the upper and lower part of the mouth here. We have the maxilla and as well as the mandible. The mandible is the jaw, all right? Then we check the mouth. All right, the chest, we're going to inspect the chest. We're going to look for any signs of injuries or anything that's noted that we need to know, and palpating, which is going to be assessing the chest. And then we're going to assess the chest rise to see if it's, if there's air going in, and abnormal breathing. Then down to the stomach, we're going to palpate the 4 quadrants, which is the left upper quadrant, the left lower quadrant, the right upper quadrant, and the right lower quadrant. And then I think we covered that in the human body. All right, and we talked about the different parts of the organs that's there. Then we go down, we're doing head to toe now. So we go down to the pelvis to make sure that there's no bleeding or any deformities. And in the extremities, which is the arms, it's upper extremities, my legs is lower extremities, we are going to check the DCAP BTLS, deformities, contusions, abrasions, burns, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. All right, we're going to check, inspect, we're going to palpate. If we find something abnormal, we're going to correct it. And pulse and motor sensation. Then we're going to do something called a log roll. In my video, you can see the log roll, very simple technique. That's going to be the time when we're going to check the back, and then we're going to log roll and check what's going on back there. And we're going to do the same thing. We're going to palpate the spine, go down to the neck and down to the pelvis. All right, baseline vital signs. The baseline is the very first vital signs you get to the scene. That's the very first vital signs. All right, so basically what we're doing with that is taking, documenting, comparing multiple sets of vital signs over a period of time called trending. So we have one first set, 15 minutes or 5 minutes later, another set, another set, another set. Then you start to see the trends. Is it getting better? Is it getting worse? All right, with respiratory rate, again, we spoke about this in the presentation on vital signs, is respiratory rate, the time. So we know that the average normal rate for an adult is 12 to 20, all right, per minute. Then we're gonna have to count. So one, I'm exaggerating, so you can see my chest rise. One, two. All right, so we're gonna count that. We're gonna look at our watch, time the watch for 30 seconds. Then we're gonna watch the needle go and count how many times you feel the beat. And once that timer goes off, as it's completed, then you're gonna have to do the math. And by doing that, we're gonna multiply it by 2, and then we have our answer. Rhythm, so there is a rhythm going on. So there can be a regular boom, 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 boom. Then we have the irregular. The irregular one is called Cheyne-Stokes respiration. Very, very interesting irregular patterns there. Then we have the quality. What is the quality? Is it silence, effortless? Is it shallow? All right. Is it normal? But this is where we're going to check that breathing, the quality. Then we're going to check continuation with this, which is basically the pulse. All right, the pulse. The pulse is an amazing part of the human body because it's all about the tubes in the body. We have tubes. All of us have tubes, and the tubes are known as vessels, blood vessels. So basically, what a pulse does is surges the blood. A surge of blood is sent through the arteries, causing that boom, 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 boom. So whenever the artery passes close to the surface of the skin or over the bone, a pulse can be palpated. So you're gonna have to check, all right? And the tips of the index finger and the long finger, again, those are just some of the things that you're gonna be using. And we'll also palpate a pulse because it's creating a pressure wave through the artery caused by a cardiac contraction. So in other words, that means is that my heart contracts, sends the ripple effect through the body. So with the pulse, is going to be 60 to 100 is normal. Again, when we do the rate, we're going to check for 30 seconds. We're going to palpate the radial pulse if they're conscious, and we're going to go over it, and then we do the math. So whatever number you have, we're going to add more stuff. So with the more stuff is the rhythm. Do they have regular rhythm, or they have no rhythm whatsoever, or there's something else going on? The quality, whether it's going to be strong, or bounding, 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 weak, or thready, where there's no period. It goes, the beat happens and it keeps going and it keeps going and it keeps going. So the blood pressure. Now this is the big toys here. This is the blood pressure. This is known as the sphygmometer. Sphygmo, which is how it's pronounced, and memometer is a measurement of this is a measurement. All right. So it checks the pressure of the circulation against the wall of the artery as that blood rushes right through the brachial artery after it's being squeezed. Then we're going to check it. And as we check it, it's going to be millimeters of mercury, and they're run by tubes. Okay. And I covered this in the previous lecture. So you have the blood pressure cuff with the gauge. We have the wide cuff. We're going to have inflatable wide bladder, which is inside. Then we have the ball pump, with one wave, and we have the pressure gauge, all right, in millimeters of mercury. All right, so let's talk about this real quickly. This is the working pressure. The highest number is the systolic number. All right, this is when the ventricles start to contract. Now, when the relaxation takes place, this is the pressure while the heart is being refilled and diastolic pressures, and now the ventricles are relaxed. All right, so we're going to listen. So this is an example of the blood pressure. We're going to wrap it on the arm. We're going to assess. Then we're going to pump. And guess what? We're going to get a auscultating blood pressure, which is going to give you the top number and the bottom number. And again, I covered this in the previous video. And the other method is known as the palpating of blood pressure. You're in a nightclub for a call. You're in a subway, construction site, very, very loud that you cannot auscultate it. So now you move on to something called palpating. So palpating is only going to give you the top number. And notice here it says 120/P. That stands for palpate. All right, so that's something, and you're going to look at other videos. I'm going to demonstrate how to check for vital signs. All right, next is going to be a terminology. The terminology is either hypo or hyper. So hypotension is when the blood pressure goes down. Hypertension is when the pressure goes up than normal. All right, play around with the words, the prefixes. They give you a lot of good information. So we have the pupils, right, constricting when light goes in. When there's no light, we have dilation. And then here we have unequal pupils. They can either have anisocoria or they can have a possible stroke or some head injuries. And then we have the skin with the same way we assess in the C step, the color, the temperature, and the condition. And last but not least, we have the reassessment. But going back a little bit here. So with the treatment, there will be a treatment, all right, involved there, depending on the type of call. And again, based on your regional protocol. All right. And I'm going to always say that, not now, but as we go further, that we always refer to the regional, state, county, or regional, wherever state you're from, we have to see that. So we're going to repeat these things. Number one, we're going to repeat the PIV. PIV. So PIV stands for reassess the primary assessment, reassess the intervention, oxygen, banishing, what else? Splinting, anything that you gave to the patient as an intervention, we have to reassess that. And last but not least, the vital signs. So the vital signs are vital, and we have to check it. All right. The very, very first set of vital signs is baseline. Then as we see it moving with other signs and symptoms, is going to be trending. So here's the number one rule is when you are transporting a patient and the patient is stable, guess what? You're going to reassess this here, primary intervention, right, and vital signs every 15 minutes. If the patient's unstable, then it's going to be every 5 minutes, okay? So going back, I just want to recap. I just thought about it. With the pulse and vital signs and respiration, we want to make sure that it's accurate. Now, if it's irregular, then this is it. This is where things change. If it's an irregular pulse, irregular breathing, we are going to, instead of the 30 seconds, we're going to go right to the minute to make sure that this is accurate. All right, so I hope this helped you. I hope that you're able to take something away from this lesson. If you have any questions, please definitely reach out to me. All right, so have a great one until the next video. All right, so let me just push this back. And listen, you are amazing. Continue to study. Have an awesome, there we go. Have an awesome day. And I hope this helped you into your knowledge and continue to get more knowledge, all right, and pass this. And then now you can watch the other videos on me presenting the patient assessment as well as other things like vital signs. All right, so I hope all is well, you're well, and you continue to be the best EMT out there and save this world. save where you are. All right. Bye. Until the next one.